Thank you for joining today's webinar. Welcome. For your information, all participants have been muted automatically upon entry to this webinar. But if you have any questions, please send them via the Q&A button, and we'll try to answer them at the end of this webinar. My name is Dorota Napierska. I'm Chemicals Policy and Project Officer at Healthcare Without Harm Europe, and I will be moderating the session today. The date for this webinar on tackling harmful chemicals in medical devices was not chosen by chance, because today, two almost 30 years old directives regulating medical devices in the EU are fully replaced by new medical devices regulation. And this new regulation contains a series of improvements compared to the old system. And among them, there was a new provision really important for a subject of today's webinar, that is stricter requirement on the use of hazardous substances. That basically means that manufacturers are now required to provide a justification if they want to use in certain medical devices and above a certain concentration, chemicals that are carcinogenic, mutagenic, reprotoxic, or endocrine disruptors. And this provision is really important because we have known for decades that some hazardous chemicals leach out of medical devices, and bisphenol A and phthalates, notably DHP, are examples of substances often found in medical devices that are of particular concern due to their endocrine disrupting properties. And unfortunately, it's still poorly recognized even within the healthcare sector that premature neonates, infants, and dialysis patients are really at risk of DHP and BPA-induced effects. So during today's webinar, we will show recent evidence of infant patients' exposure to DHP during the course of clinical care. We will highlight current knowledge deficits among healthcare providers on this issue, and hopefully we will raise awareness and inspire healthcare providers to seek safer alternatives and demand for PVC and DHP-free medical devices. And all this will be done by our three speakers: Dr. Elisabeth Eckert, postdoctoral researcher at Friedrich Alexander University in Germany, Dr. Miriam Bickel-Gras, pediatrician at Woman Mother Child Department Neonatology Service at Hospital Center Vaudois University in Switzerland, and Elaine Med, Director of Improvement Care and Compassion. But before I invite the first speaker, I would like to provide a really short introduction to our organization and our work on harmful chemicals in medical devices. Healthcare Without Harm is a non-profit European network of hospitals, healthcare systems, healthcare professionals, research academic institutions, and environmental and health organizations. And Healthcare Without Harm is a global movement with 3 regional offices in Europe, North America, and Southeast Asia, virtual team in Latin America, and partners who run programs and develop our network in regions where we do not have offices or staff. Following Hippocratic Oath, do no harm to people or environment, our mission is to transform healthcare so that it reduces its environmental footprint, becomes a community anchor for sustainability, and a leader in the global movement for environmental health and justice. And our European members are also part of the global movement, network of global green and healthy hospitals, which grown to a community of 1,450 members in 72 countries. So why we are talking about harmful chemicals? Well, while exposure to hazardous chemicals arising from industrial activity, use of everyday personal home care products, etc., is well recognized, the role of healthcare in exposing individuals to such chemicals is still grossly underappreciated. And Healthcare Without Harm Europe has long campaigned to highlight and reduce these exposures for patients, especially for vulnerable populations, such newborns, pregnant nursing women, and those receiving the treatment via multiply medical devices. And we produce numerous fact sheets, reports, infographics, webinars, showing that, in fact, safer medical devices that do not contain PVC, DHP, or BPA exist. And you can find all of them, all those materials on our website under Safer Chemicals resources. And I would like actually particularly recommend to our most recent publications both from December 2019, so updated second edition of Non-Toxic Healthcare Report, as well as a report from our workshop that took place in Brussels in December 2019, where you can find a lot of relevant up-to-date information on scientific, regulatory status, availability of alternatives, best practice examples, etc. And that would be all from my side. So I will now stop sharing the screen. And I'm happy then to invite our first speaker. Yes, Elizabeth. Elizabeth holds a doctoral degree in food chemistry and has recently qualified as a private lecturer in occupational and environmental medical toxicology. And since 2014, Elizabeth has been part of research project concerning plasticizer in medical devices. And this project aims to identify different strategies to reduce plasticizer exposure for patients and hospital employees due to medical procedures. So please, Elizabeth, the floor is yours.
Thank you very much, Dorota. I'm happy to be here today, and I hope everyone can see my presentation right now. Otherwise, please.
You can see you well.
Thank you very much. So I will start to give you a short overview about our recent work. As Dorota already said, we have a very successful cooperation since several years from our Institute of Occupational Medicine together with the University Hospital in Erlangen, Germany, more specifically with the pediatric cardiology, and we are looking on plasticizers and medical devices with the aim to reduce the plasticizer exposure. I want to give a short background. As you will all know, that plastic medical devices are now essential equipment in hospital and are used for a lot of disposable medical devices like tubings, blood bags, infusion sets, etc. And these medical devices often contain plasticizers in relative high amounts of 20 to 40% per weight. So you can say that about 1/3 of the actual plastic material is pure plasticizer. And these plasticizers are not chemically bound to the plastic matrix, and therefore an exposure due to migration is easily possible. And here you can see a standard heart-lung machine that is used for cardiopulmonary bypass procedures in children. And if you take a closer look, you can see that there are really a lot of tubing materials. And so you can imagine that during such a procedure, there's a lot of the blood of the patient comes into contact with plastic medical devices, and therefore a migration of plasticizers into the blood is possible. Especially because there is a very large surface of the tubing material, so that an elevated migration is to be expected. And we started our project by doing an in vitro experiment, and therefore we we used an heart-lung machine that is that you can see here, and we filled the tubing material with animal blood, more exactly with sheep blood, and let it perfuse over 24 hours. And we used two different tubing sets. One tubing set was plasticized with a standard plasticizer DHP, and one with an alternative plasticizer with THDM. And here you can see the structural formulas of both plasticizers. And as you can see, they are really similar, but THDM contains an additional third side chain, which supposedly leads to an enhanced stability of the plasticizer in the plastic matrix. Yes, and we, as I said before, the blood was perfused through the tubing systems during 24 hours. And we took blood samples at different time points to look at the plasticizer content in the blood. And yes, and this was done under realistic conditions as it would be if a surgery took place. And here you can see our results. In the top row, you see the results for the plasticizer DHP and its primary metabolite MEHP. And here you see the results for THDM and its diester and monoester metabolites. And as to be expected, the plasticizer content increases with increasing perfusion time. This is true for both plasticizers, for DHP and the alternative plasticizer. But if you take a look at the scale, you see that DHP migrates a far higher amount than the alternative plasticizer. And all in all, we found that the migration rate of DHP is more than 350-fold higher than that of THDM. And if you keep that in mind, that the migration rate is so different between both plasticizers, and then we take a look at the toxicological evaluation of both plasticizers, you see that DHP is classified as carcinogenic, group 2B by IARC, but more importantly, it is evaluated as an endocrine disrupting chemical and is therefore linked with reproductive and developmental toxicity effects. And therefore, DHP was already banned several years ago for use in toys and childcare articles. But interestingly, there's no such ban for medical products, and so DHP is still one of the main plasticizers used in medical devices, even for susceptible population groups like newborns or children in general. On the other hand, if you look at the alternative plasticizer THDM, you have to admit there are fewer data available, but all available data indicate rather low acute and chronic toxicity potential. And you can also see the difference if you look at the TDI values, that means the tolerable daily intake values. The TDI of DHP is only 50 microgram per kilogram body weight, while for THDM it is much higher and above 1,000 microgram per kilogram body weight. And those two factors, the first, that the migration rate of THDM is so much lower than of DHP, and the fact that the toxicological potential is also lower, led to the decision of the pediatric cardiology department of the University Hospital in Erlangen to switch exclusively to THDM containing blood tubings. And now, of course, we wanted to see how is the real exposure situation in the patients. And therefore, our working group started first to take a closer look on the alternative plasticizer, because to evaluate the exposure situation of patients, we need biomonitoring methods. We need to know how is this metabolite, this plasticizer metabolized. And I don't want to go into the detail, but also we did some in vitro studies, and we did a pilot human study where 4 volunteers were overly exposed with this plasticizer. And we concluded we could establish a metabolism scheme for this plasticizer, and we could show that THDM is rather slowly metabolized and has low absorption rates. It means even if THDM is ingested, the main portion is excreted unchanged via feces. But there are metabolites in urine, and so we were able to develop biomonitoring methods in blood and in urine. And here I want to show you the proposed metabolism scheme, but I won't go into the details. I just want to show you that there's really a complex metabolism. There are several primary and secondary metabolites that are highlighted here that we did found in urine, but all in all metabolites did account for only 6% of the oral dose, because, as I said before, most of the plasticizer is excreted unchanged via feces. But nevertheless, now we had the possibility to take a look at the infant patients itself, and that is something I want to share with you, because we did a pilot study with infant patients. All in all, there were 21 infants aged 4 to 22 months with a median weight of about 5 kilograms, and all of these infants had to undergo cardiac surgery at the University Hospital in Erlangen using such a CBB procedure, as I have shown you before. And as I said before, we used exclusively THDM containing blood tubes. The bypass time, that means the time at the machine, was about 2 hours, so a rather short procedure. And an important point is that all infants but one received also blood products during the surgery. That means erythrocyte concentrates and fresh frozen plasma. And we collected blood and urine samples both before and after the surgery, and analyzed both for the plasticizer content and for the metabolites of both plasticizers. And I want to start to show you the results in blood. As expected, we did not find any alternative plasticizer before the surgery. That is here labeled as T1. And after the surgery, T2, we did found the plasticizer in the blood of the children, which was to be expected because we used THDM plasticized blood tubings. But I would say that the amounts that we did found in blood were rather moderate. But we did also look on DHP. And as you can see here, after the surgery, we found still highly elevated levels of DHP. Also, as I said before, DHP was not contained in the blood tubings. And even, and again, if you look at the scale, the levels of DHP in blood were much higher than that of THDM. And we concluded that DHP has to be originate from the administered blood products, because the blood bank of the University Hospital in Erlangen is still working with standard medical devices. That means they're still using mainly DHP containing blood bags. And so we analyzed the blood products itself too. And we did found really high levels of DHP in both the erythrocyte concentrates and the fresh frozen plasma, and there were levels in the microgram per liter range. And I did a short calculation given the amount of the administered blood products to each patient and the DHP levels of the individual blood products. And there I could calculate that each infant patient received about, on average, over 600 microgram DHP per kilogram body weight. And just if you take that into comparison with the TDI level, as I said before, which is only 50, you see that just one small procedure exceeded the TDI for the for DHP very much. And you have to keep in mind that these are children who are really supposed to be very susceptible to the adverse effects of DHP. And so, and you have to keep in mind that we used DHP-free tubings, and otherwise, if we had not done those, the amount of DHP in the blood would have been even higher. And secondly, I told you that we also looked at urine samples, and we did not find any metabolites of the alternative plasticizer in urine. This may be due to the fact that the amounts in blood were already rather low, and that THTM, as I said before, is not excreted mainly per urine, so that the levels were supposedly too low for us to see. But we did observe DHP metabolites, and as expected, we found higher metabolite levels after the surgery than before the surgery. This is true as well for the primary metabolite as for the secondary metabolites. And as you can see, we also found DHP metabolites before the surgery, which is logical because DHP is now ubiquitously present. That means that we always find DHP metabolites in all human beings. But after the surgery, there was a significant increase. So I am already at the end, and I want to conclude that we could show that the migration rate of plasticizers into blood is strongly dependent on the type of the used plasticizer, and therefore I'm really happy that the pediatric cardiology department decided to use an alternative plasticizer in their blood tubings, and the plasticizer THTM appears really to be a suitable alternative to DHP as well, due to its low migration rate and due to the presumed low toxicity potential in comparison to DHP. And the THTM containing blood tubings are now applied for several years there in the hospital, and there's no negative application effect to be noticed. So there's really no reason why you shouldn't use another plasticizer. But still we have to conclude that the inner burden of infants with DHP after cardiac surgery is still critically elevated due to DHP containing stored blood bags. And we are now talking to the blood bank, and we try to convince them to try out alternatives, but that's always not easy. But we hope that we will be successful in time. And so I conclude that I think that the use of DHP in medical devices should be further restricted, especially for the treatment of sensitive population groups like infants. So now I'm at the end, and I thank you very much for your attention. And I think questions are at the end of the whole session. Thank you.
Yes. Thank you very much, Elizabeth, for sharing results of your study. Very clear and interesting. I think the message is also very clear. And indeed, we ask the panelists, if you have the questions to Elizabeth, please submit them via Q&A button, and we will address them at the end of this webinar. And now I would like to invite our second speaker, Dr. Miriam Bickel-Gras. Miriam is developmental pediatrician affiliated with a large care neonatal center. And she has published several publications on the presence of phthalates in neonatal intensive care units a review of phthalates in child development, and a survey on the knowledge and awareness of neonatologists on this subject. I also would like to mention that Miriam is a member of Doctors for the Environment, a Swiss association, and she believes that healthcare professionals must commit to limiting the impact of environmental pollutants on future generations. So, Miriam, over to you.
Thank you. I'll just make some advertising. We have a huge demonstration in front of the WHO this Saturday, so look out for it on your TVs, Doctors for the Environment. So I'm going to speak about phthalates in the NICU, a bit the same population as you just had now with Elizabeth. In the neonatal intensive care units, everybody thinks preterm infants. Actually, about 1/10 of them are preterm. In the world, 1 baby out of 10 is born preterm before 37 weeks of gestation, which represents 15 million babies each year who are vulnerable. Most studies and most researchers focus on children born before 32 weeks of gestation or below a weight of 1,500 grams. Those are the more vulnerable children. And they are vulnerable, and from a neurodevelopmental point of view, with cognitive impairments affecting about 40% of these children, not a whole cognitive impairment, but maybe a speech disorder, a movement disorder, or something. So twice as much as in the general population. Motor impairments with cerebral palsy affecting up to 10 times more than in the general population. So 10 to 20% of these children could have a motor impairment of one sort. And finally, one of the outcomes more recently studied is behavior with social impairments such as autism spectrum disorders affecting up to between 2 and 10 times more than in the general population. So most of the children born before 32 weeks of gestational age are followed up in specialized centers in university hospitals, at least in Europe. The impact on neurodevelopment after preterm birth is due to several things. Among them, what is very well known and researched is gestational age, birth weight, gender, with boys having more risks than girls, infections, severe lung disease, genetic problems, and pain all have been studied and shown to be related to the development of these children. More recently, in the last 15 to 20 years, what is called developmental care has been studied with a restriction of sound, of noise, with the use of music and maternal voice to help the child. There has been work on nutrition, on sleep, on the preservation of sleep, and all these things will affect the outcome of the long-term outcome of these children. So this part of the child's environment during the NICU stay is called the environment, and it's very varied. And in this environment, of course, there is all the chemical products we give to them during this day. So there's, of course, all the drugs they get, antibiotics, amines, all kinds of drugs, cleaning solutions, because everybody's wary of infections in the neonatal unit, hand disinfection. I won't tell you how many times we do that these days with the COVID pandemic. Medical devices, of course, diapers, nutrition, mother's perfume, nurse's perfume, you name it. I mean, those babies are given a bath of chemical products every day. So among all that, medical devices, of course, is the topic of the day. And we know that there are phthalates in medical devices, in NICUs for babies, in adult intensive care as well. And they, as has been already said, used to enhance the flexibility of medical devices. A recent study has shown in the NICU, so for really preterm babies or neonates, the outcome which is most related to the presence of phthalates is ventilation. So the more they need ventilation, the higher are their phthalate levels. So it's not from the infusion lines or the feeding tubes, but it's more from the ventilation material. But the gloves, the dressing, the monitoring equipment, everything is made out of plastic. The Swiss legislation has said since a few years now that phthalates must be and have to be identified on the packaging of these medical devices. Because we know that they exist, they are probably a necessary evil to save these babies. But how necessary are they? And I'm very happy to have heard that alternative materials exist and seem to be more and more used. The labeling on the packages is very varied. There's not one, it's not uniform. As you can see with yellow, the shape of those symbols is very different from one box to the other. And so colleagues of mine in the unit made a study, a survey between 2014 and 2017. And they did a systematic survey of all the medical devices used in the unit. They found 354 medical devices in the unit, and they looked on the box, they looked on the packaging. When they didn't find anything, information, which happened quite a lot, they contacted the providers, they contacted the industry. Some industries had to be contacted 10 times before they answered. And at the end of the way, they found that 10% of these medical devices contain DEHP, and in 13% of them, we didn't know. Nobody knew, nobody knows what's in them. So it's quite clear that phthalates in the neonatal unit are a problem, are present. So it is also known that it's a problem, as Elizabeth just told you. The publications have shown that the level of phthalates in the baby's blood are due to leaching, and that the temperature of the room or of the blood or anything increases the leaching. And in lipid solutions, like the one we give to preterm infants to fatten them up, there is more leaching. Long-term ventilation seems to be a really big risk factor, and some of those babies born at 25 weeks with a birth weight of 500 grams will need ventilation for sometimes 3, 4, 5, or 6 months. So those babies are particularly at risk of very high DEHP content. The publication very much cited by Mallow shows that critically ill infants are subjected to hepatotoxic and reproductive levels of phthalates very, very much higher than the limits which are normally accepted. What we know from animal models is that depending on gestation age, birth weight, behavior, and all that, there is an impact between phthalates and the outcome of pups, rats and all that. And in human epidemiology, there seems to be a link between an association with phthalate exposure and gestational length, birth weight, and in endocrine disruption. And postnatal exposure, like the one we find in the NICU, could be associated with inflammation in the lungs, in the gut, in the eyes, and possible neurodevelopmental. There is no association we can talk of. We can't prove it, but there is a biological plausibility relationship between the two. After preterm birth, we know that the neurodevelopmental outcome after preterm birth, or after birth asphyxia, or after gestational antidepressant treatment, after migration, after congenital infections, is linked, statistically linked, with an increased risk of autistic spectrum disorder or of hyperactivity. There is a link as well in some large studies between phthalate exposure and autistic spectrum disorder and hyperactivity. Those are statistical links in large administrative databases, so it's to be interpreted with caution, but it's possible that these phthalates have an impact on the neurodevelopment of these children. DOHAD is a very large field of research. It's called Developmental Origins of Health and Disease, which studies what happens during the first month of life of an infant, starting in utero and during the first month of life. We know that the brain of a newborn infant weighs about 500 grams, and it will weigh 1.2 kilos at the age of 2 years and 2 kilos as an adult, and then it loses weight. Maturation is huge during this period because the brain forms new connections all the time. There is a very high lipid content in the brain. The blood-brain barrier is not very efficient in stopping some chemicals. And so it's really a big period of vulnerability where you can stop those connections from forming. So this period heightens the biological plausibility that phthalates may harm neurodevelopment in these children. In the reviews in animal models, phthalates do cell damage in the brain of the pups, and they lose brain cells with learning and spatial memory problems afterwards. In neonates, in term neonates, there is a possible link between maternal urinary levels during pregnancy and the outcome of the neonate. And in preterm children, funnily, there were better scores associated with infant urinary. So it's a bit weird. In children, older children, there's a link between maternal urinary levels and cognition in the child with conflicting results. So all this shows that it's a field of research which is very difficult to apprehend and to draw definite conclusions from. All those diagnoses are clinical diagnoses which should be made face-to-face, but we are made with questionnaires in big databases. The association between child urinary levels and outcome give conflicting results as well. So there's a possible, we do know there's a possible neurodevelopmental effect, mainly in boys, but we haven't proven it yet. It's difficult to prove. So there's this problem of the phthalates in the NICU. So we made a survey to know what our colleagues knew about it. And we made a survey to French-speaking neonatologists, senior neonatologists in France, Belgium, and Switzerland. And we sent them this survey to all of them. Had heard the response rate was fairly good, 70 to 80%. About half of them had heard already about phthalates. Only half of them had ever heard about it. And when we asked them whether they thought there were phthalates in the unit, 35% thought there might be. When we asked them whether they had a means to identify phthalate-containing devices, 40% said yes, and for a limitation strategy in the unit, there was none in most units. So that means most neonatologists, they don't even know the problem exists. So of course, we have to start doing some teaching. That's most important. And we have started to make more research about that. I just checked to know, and I can't see my whole slide because of the thing here, but it doesn't matter. I'll tell you anyhow. This is the number of publications on phthalates in humans in between 2019 and 20. And this is 220 and 21 because everybody's now researching COVID. So we have to put the foot back on the pedal and get back to studying phthalates and let specialists do COVID. So take-home message, preterm and critically ill neonates, of course, have an increased vulnerability to an increased skin and body weight ratio, immature metabolic pathways, and the cocktail effect of all the numerous chemicals they get. They might stay in the hospital up to 6 months, and they get very high doses, which are very much higher than the toxicity levels. There's possible long-term effects, I say possible, we're not sure, on neurodevelopment, endocrine disruption, lungs, eyes, and all that. And most of the neonatal specialists are not even aware that they are harming those babies. That's why we're going to do healthcare without harm. So we have questions remaining about the intensity of the exposure and the outcome, and alternate and safe medical devices. We just heard about that, and how to do biomonitoring with such small quantities of material, such as we have in 500-gram babies. So back to work, and questions at the end of the talk.
Thank you very much, Miriam. That was very good presentation. Again, very clear, and I think that the message was more than clear. All panelists are asked to pose any questions via Q&A button, and I will immediately invite our third speaker, Elaine Mate, to share her screen. And in the meantime, just wanted to remind what was shared in the bio during our website, that Elaine has enjoyed over 32 years experience in healthcare in the UK, having trained originally as diagnostic radiographer, moving into leadership after completing an MBA, and she has also experience in implementing a large-scale change as chief executive of NHS in the north of Scotland. And now as director of an organization supporting leaders in quality improvements across the UK and Europe, Elaine has increasingly become aware and engaged in the impact that healthcare has on health and the environment. So please, Elaine, go ahead. I don't see your presentation yet on the screen.
No, I need Miriam just to take down hers if she could. Miriam, thank you. Perfect.
That's perfect. We still have 15 minutes.
We do.
So I don't want you to rush, Elaine, in any case.
It's fine.
That's the last slide, I'm guessing.
Yes, I'm just trying to, these are not my slides. I'm just trying to get into those.
Well, so just in the meantime, I will see that probably we won't have much time to answer the questions ad hoc during this webinar. I see some of them already arriving, so I can propose that we eventually can answer them after the webinar. Those who ask the question are registered, so we will have your email and we will approach to you individually. That is.
I'm sorry, I'm trying to go back to the beginning.
You are going there, so just I think you are just at the very end. Yeah.
And I can't. Yeah.
No, I think your exit.
Try again.
Let's try again.
I can't get rid of something on my screen. Can you put my slides up for me then, and we'll just ask you to share the screen?
So do you want me to, that I will go just...
Thank you. That would be easier. I think I'm so sorry. I can't get rid of
No, it can happen.
Screen.
I know we tested it, but one second. I will open your presentation. Okay, so you have to stop sharing and then I can start sharing my one. I think, Elaine, you are still sharing your screen.
I'm trying. Right, hang on. Let me see if I can go back to the beginning. Now, how should we try it? How are we there? Are we good? Okay, thank you, and apologies for that. Let me take us straight into the presentation then. So I'm Elaine. I'm independent director of a small organisation, Improvement Care and Compassion, and spent 35 years as a healthcare professional and manager in the NHS. I've been clinically trained as a diagnostic radiographer, and for the last 8 years in the NHS, I've had the privilege of being a chief executive of an integrated health and care system in the north of Scotland. And I'm here to tell you my very personal story on chemicals in medical devices. So let me take you with me to the night of the 31st of December, 1999. Can you remember where you were? And it was an exciting time. It was the turn of the millennium. I remember it very clearly. At that time, I was the manager for a women and children's services on the south coast of England. As a management team, we'd been preparing for almost 2 years for year 2000, and we had spent literally hundreds of man hours at meetings. We genuinely thought that there was a risk that healthcare would stop as the clocks in our what now looks like primitive technologies changed from 99 to 2 zeros. And it seems very strange now, but that was very real then. So I found myself here on a busy neonatal unit with 12 cots of premature infants, some of which were ventilated, nearly all who've had some kind of syringe driver or electronic medical device. And we genuinely thought they might stop. I was the service manager responsible for developing those year 2000 plans, but I was actually part of the contingency plan for the night. All of our staff were trained and ready to handbag the babies and to count drips if necessary. I know now it sounds ridiculous, but this was 1999. We, like most places, were watching exactly what happened in Australia, and I would say on reflection that we learned more in 12 hours than we had in 2 years. And as the night went on, we became more confident that this disaster wasn't going to happen. The parents and staff were reassured and the bells passed with no excitement. The babies were safe. But when I look back now and think about that environment and that equipment, how safe were they? Fast forward now for me to 2020. I've left the NHS and I've more time to follow my personal interests and follow up on another passion, pharmaceuticals in water sources. That led me to join the Alliance for Water Stewardship, international charity that's committed to ignite and nurture global leadership in credible water stewardship, but that's a story for another time. What I did do as a result of joining was to read a lot more about the impact of healthcare on the environment and the consequences of that on human health. So I read the Kathy Gerwig book, may have come across it already, Green Healthcare, published back in 2015 about how hospitals can heal the planet. And I was shocked. I was genuinely shocked. On page 2, she said that some of the medical equipment widely used in NICUs might contain a chemical substance to make them soft and flexible, but that can leach out into solution and subsequently into the patient. She went on to say that in the late 1990s, several animal studies had suggested that exposure to these phthalates could be harmful to the developing fetus, especially in the reproductive system in males, as we've heard already today. So, oh my goodness, in a second, reading that, I was back at midnight in that neonatal unit. I didn't know. Why didn't I know about this? So I was reassured to hear that Kathy and her team in Kaiser Permanente went on to do some great work, converting nearly all of their medical equipment and their IVs to plastic-free alternatives. So there was some great work happening, but being curious about this now, I wanted to find out more. I'm not a chemist. Radiographers like physics, but I had to learn new words, I had to understand new concepts, and now I knew about chemicals and their impact on health. I realized that actually the decisions that I'd made procuring equipment and medical devices as chief executive were not based on fine science or knowledge. I actually thought back to it, what would I have done if I'd known then what I know now? And these might have been some of those things that I would have done. Hindsight's a really wonderful thing. So even though these are the things I might have done, honestly, in 1999, I doubt that this would have made any impact. As a relatively junior manager with little influence, I would have been probably told to get on with sorting out safe transfers or something else that was really important at the time. I'm unlikely to have got to speak to some of those representatives. They'd be busy speaking to the consultants likely. Clinical colleagues at that time, I'm sure, would have pointed out to me the obvious benefits to the patients of the equipment that we were using. In summary, nothing would have happened. And hey, guess what? Nothing actually did. So what is it then about the humble giving set that's surrounded now by such controversy? And clearly it's not just the giving set, it is all the plastics that we've heard, the tubing, the equipment. Clearly we need the plastics for the ease of use. I'm not against plastics in medical devices, but we definitely now know that they do cause harm. We also now know that there are suitable alternatives, but the arguments are confused. I read just this week that Plastics Today, an organisation promoting plastics, are encouraging recycling of the materials by the NHS. When I was the chief executive, I thought this was a great idea. Now I know what I know. Is it such a great idea? Should we be recycling those very things? We know that the costs less at the moment to procure the devices and make these devices, but that's going to be market driven. So the manufacturers can do it. Kaiser Permanente showed us that, but why would they bother if there's no demand? So it's the long-term impact that we've heard about today that's now becoming clearer, but with all the other exposure to toxins during life, is there and can we prove a definitive cause and effect? So how can we raise it or even discuss it? And how ethical is it not to? Because clearly we don't want to cause additional anxiety to families nor to spoil their new baby experience. But is our silence unethical, or do we just not know? I, for example, have only just found out about the toxics in mother's milk, which is a whole other issue, but you see my point. It's not their problem, it's our problem. And we can't change everything, but should we change something that we know is harmful, and do we have enough evidence? So some would say we do. Here's the UK MHRA advice from their website just yesterday. We know there's a problem. They know there's a problem. But actually understanding those problems is different to doing something. They are quite cautious. We all recognise the clinical benefits and the necessity of the medical devices. And do we need to understand now more about the impact of the alternatives? But should that take us, and has it taken us 20 years? Where is that research? Some of you are all there already, and thank you, Elizabeth, for that presentation and the work that you're doing. I applaud my colleagues for the positive action that they've taken across Europe, and welcome the new recommendations and legislation which must drive change. And Miriam, I must add Switzerland to my list here, but will these recommendations be put in place in the UK? That's the question for me, and I don't know, but I plan to ask. So what can you do? You'll be here today because you're interested, and forgive me for stating the absolute obvious, but you are likely to be best placed to make change happen. Healthcare Without Harm is giving us this platform today to mobilise action. And if you think this is important, maybe here are some of the ways that you can make others think that too. There are over 1 million staff in the NHS in England, and the voices are getting louder, some louder than others, about climate and sustainability, but you could use your position and knowledge to create a better future. if you were to do that, you'd be using already and contributing to the United Nations Sustainable Goals of good health, responsible production and climate action. And of course, while we can't prevent all the exposure to plastics, we might be able to do something positive for the children. So I thank you for what you do every single day. I wish you well on your journey, and thank you very much for listening. I'll pass back to Rota to you.
Thank you very much, Elaine. It was thank you for sharing your also the personal view, and I really appreciate also the message. You concluded your presentation. That's basically more or less the wrap up of our webinar today. I can only actually also applaud the message you just convened. We have 3 minutes, so it's not really so much time. I will just maybe just start to share my. Well, so as I mentioned, we won't be able to answer really all the questions, but maybe I will just try in this last 2 minutes ask at least 1 or 2. The question, I'm really sorry, I'm just I just lost them now. I'm sorry. I do have to stop sharing, unfortunately, because I lost them from my. Okay, so the first question would be to Elizabeth. Is there any good chemical background procedure you can recommend for human or laboratory on home uses? I'm guessing that this is about chemical background of measured chemicals that you did the measurements in the hospital.
Oh, there are several background procedures, and we always try to analyze also the environmental background, because we can compare. So I don't really know if you're looking for a special method, because there are so many in the literature, and we have just nowadays really methods who are able to analyze a lot of plasticides and alternative plasticides simultaneously. So I don't really know what exactly you want to know.
Yeah, well, unfortunately, I cannot, I think, really expand a lot on this question. Maybe then the second question is that, well, it will be also to you, Elizabeth, maybe also to Miriam. Are you aware on the project that was already finished in Europe on PVC-free blood bags? And by any chance, if you are in the contact with Karolinska Hospital in University, that are still aiming to do some innovation into this. So basically, by producing PVC-free blood bags, that would at the same time solve the problem of plasticizer.
Yes, thanks for the info, but I had not contact there, because I'm not. I'm more the analysis, and yes, so my colleague is doing all the other things in the hospital. But as I said before, we are right now talking to the blood bank, and we are starting right now another project, and I hope that we will have success to convince them to use other blood bags than right now. But I think that there also has to be a change in regulation, because as good as it is right now, there's still the loophole that you can just claim and and say that you need to use DHP, and you give a reason, and then it's okay. And I think that's not the way to go. If you look at France, it is now already possible to have medical devices for children that are DHP free, and I think that's the way that we have to go in all Europe.
Thank you, Elizabeth. We already 1 minute after 2, so I'll have to stop asking the questions. As I said, we'll try to reach all participants who pose the questions individually. So I hope that today's presenters will also help to find the answers. So thank you very much for participation. Thank you very much for all 3 speakers to giving this excellent presentations. If you have any further questions about this issue, please contact me. As I said, today is the deadline of implementation of the new medical devices regulation, and there is some provisions that should help, and we only hope that there will be really all those procedures will be implemented properly, and we will see some improvements. So there will be really push from the regulatory and policy point of view to improve. So once again, thank you very much to all the participants, and I hope that we will have opportunity to continue this discussion on another opportunities during another meetings and events. Thank you very much, and I wish you the very good rest of the day. Thank you.